Unfortunately, I don't have a cool accent like Dr. Calvas. Let's see. Let's go. So I don't have any disclosures. So today we're going to talk about a couple of common hand injuries you may potentially see in clinic, and then how to diagnose them, how to treat them non-operatively, and then sometimes I'll give you indications as to when to refer to a hand surgeon. And so the most common thing you'll see is probably carpal tunnel syndrome. Anyone here have carpal tunnel syndrome? I have carpal tunnel. And so we'll discuss this, and then we'll spend maybe like 10 minutes on that and the rest on the other diagnosis. So carpal tunnel syndrome, we have to know what's in the carpal tunnel. So in the carpal tunnel, there's basically 9 flexor tendons, all the flexor tendons to your fingers. Each finger has 2 flexor tendons, usually. And then there's also a flexor tendon to the thumb and then the median nerve. So compression of the median nerve with irritation is carpal tunnel syndrome. The distribution of the carpal tunnel syndrome, so the palmar 3.5 digits basically is where the innervation of the carpal tunnel is. So the thumb, index, the middle finger or the long finger, as we refer in hand surgery, and half of your ring finger. Keep in mind there are some variations, so not everyone reads the anatomic textbooks, and so some people will have different innervation, but this is basically what most people will have. So the anatomy of the hand, basically most of the muscles in the hand is innervated by the ulnar nerve, except for the thenar compartment and 2 lumbricals. So in regards to carpal tunnel, what we need to worry about is the off muscles, the opponens pollicis, abductor pollicis brevis, and flexor pollicis brevis. But in terms of our exam, what we should focus on is actually this more superficial muscle, the abductor pollicis brevis. And I'll show you how to test for it and what to look for on a clinical exam. So etiology, most of it is idiopathic. Most of the causes of carpal tunnel is idiopathic, but there are some anatomic cases that do present, and systemic factors. You'll probably have a lot of patients who have diabetes. A lot of them also will eventually get carpal tunnel. Occupational exposure, I always get this question. I type a lot in my computer. Do I get carpal tunnel? Can I get workers' comp? And there's actually there has not been a proven direct relationship between repetitive work and carpal tunnel syndrome. But the caveat is in certain states, you could actually get workers' comp based on this. And like in Wisconsin, I believe we used to give workers' comp for this when I did fellowship. Rare anatomic causes, the zebras, tenosynovitis, rheumatoid patients can have it. Some people can have, tuberculosis, and they could have rice bodies in the carpal tunnel, abnormal muscles, tumors, and so forth. Those are rare. The systemic risk factors, diabetics, hypothyroidism, and this one, I want to highlight this one, pregnancy. A lot of pregnant women, after they give birth, will develop carpal tunnel syndrome, and most of them don't need surgery. A lot of times, a steroid injection will get rid of that. So I just put this up for reference. I mean, there's a lot of causes for carpal tunnel, but most of them are idiopathic. So this is how people present in clinic, and a lot of times you could tell they have carpal tunnel by the way they describe their symptoms. They'll say, I wake up at nights and my hands are asleep. I have to shake them to get the blood flowing again. I have to run them under warm water, and then I can go back to sleep. Fingers go numb when I drive. My hand goes numb when I use my cell phone, sometimes when I text. I'm always dropping things. The reason why people get nighttime symptoms is because the flexors are actually stronger than your extensors. So when we sleep, we actually sleep in the fetal position, so our wrists flex. And that's why when we give a nighttime splint is to avoid wrist flexion. Can't button my shirt. So the diagnosis, this is how you diagnose. So when you do a motor exam, you look for weakness and also atrophy. This is one of the pictures of how to test the abductor pollicis brevis. I like this picture as well. So basically I asked them to do palmar abduction in the plane of the palm, perpendicular to plane of the palm, like this. And we'll go over that in the demonstration. And this is so abductor pollicis brevis is right there. It's a superficial muscle. And so this is what thenar atrophy looks like, severe thenar atrophy. Provocative test for carpal tunnel tunnels is you tap and you're trying to irritate the median nerve. So when you tap it and they say yes, it hurts, that's not positive. They actually have to have like an electrical shooting sensation to their fingers. So I asked them, do you feel anything in your fingers? And a lot of times they'll just point and do this, and that's a positive test. If it hurts, it's not a positive test. Phalanx, like I said, flexion will decrease the volume of the carpal tunnel, and so phalanx test is actually flexing the wrist. And so that will elicit symptoms of median nerve compression. I like this test a lot, the Durkin's test, which is the most sensitive in the literature for carpal tunnel, is compressing the median nerve. We'll go over that in a second. I rarely use this. I do use this sometimes when a patient comes in and they're numb everywhere. I'm not quite sure if they have carpal tunnel, and so I have them do the phalanx test like this, and they say, yes, it's numb, and then I have them do the reverse phalanx, which is also decreasing the volume of the carpal tunnel, and they say, oh, yeah, it feels great now, I'm not numb anymore. Then it might be a supratentorial, okay? So when you tap for the Tinel signs, you can't be gentle. You have to really tap on it to irritate the nerve. And so what you're trying to do is elicit an electrical signal. This is the phalanx test. It was actually originally described with the elbow extended. And the reason I like to extend the elbow is because you're putting the median nerve in stretch. Clinically, I don't think it makes that big of a difference, so you could have them do this for the phalanx test. But I like to have them go straight out like this, okay? And one question is, how long do you wait? Usually when you get a positive test, you'll probably get it within the first 15 seconds, but then some people wait for a minute. This is the reverse phalanx test. And the Durkin's carpal compression test. So I like this test. I put my finger over the carpal. This test, I usually put my thumb here, not here, over the transverse carpal ligament. And I do a little variation where I compress and I also flex the hand a little bit. So I do kind of like a phalanx / Durkin's. And I think that for me, that's a very sensitive test. And we'll go over that in our exam. So diagnosis of carpal tunnel syndrome is actually clinical. So people will come in with nighttime symptoms, the history makes sense, the physical exam makes sense, then you actually don't have to get an EMG. But in clinical practice, sometimes we do get an EMG for a couple of reasons. Sometimes the insurance companies may require it. I also get it for confirmatory testing and establishing a baseline. So if they have severe symptoms, I want to make sure that I have that documented, because not all carpal tunnels respond the same to surgery, and I'll discuss this in a second. And then if you think they also have symptoms coming from their neck, cervical radiculopathy, so if they have neck pain, plus or minus, and they say it goes from my shoulder to my elbow to my hand, they might be coming from the neck. Then I also get EMG to make sure it's not from the cervical spine. And then also what clouds the picture in diabetics is this peripheral neuropathy. Unfortunately, even though you do the carpal tunnel release, they may still have, they will still have the peripheral neuropathy, and so managing expectation is key. So non-operative options and surgical options. I'll briefly discuss what we do in surgery, but then I like to focus on non-operative options, what you can do in your clinics. So there's a couple of stages of carpal tunnel. So there's mild carpal tunnel, which is usually duration less than a year. Numbness is intermittent, so it comes and goes. Usually at nighttime when they sleep is when they get the numbness, or when they have actions where they bend their wrist. Their sensory and motor exam is usually normal, and the EMG will say mild carpal tunnel syndrome, okay? And there's moderate, where now it gets a little bit worse. The numbness is a little more frequent, more continuous. Their sensory testing might be abnormal, and then EMG will say moderate carpal tunnel syndrome. In severe carpal tunnel syndrome, you have thenar atrophy. And so the reason we like to classify it this way is because mild patients, we usually try like a splint. Moderate, usually try a splint or injection. And severe carpal tunnel, for me, once they have thenar atrophy, for me, it becomes a surgical problem. You should fix this. Now, in terms of recovery, this is what I tell all my carpal tunnel patients. If you have baseline numbness, that may or may not get better with surgery. It's unpredictable. The thenar atrophy won't get better, But it's really good for like the nighttime awakening symptoms. And so it's really important to manage their expectations, because if you do a carpal tunnel release in someone who has severe carpal tunnel syndrome and they don't get better because you didn't tell them ahead of time that it's unpredictable, then they may be dissatisfied. And so I think for you guys, if someone has, let's say you do get an EMG and someone has moderate or severe carpal tunnel, I think it's prudent to refer to a hand surgeon for possible surgical intervention. Non-operative treatment, the mainstay is night splints, and this night splints should be used mostly just at night, but some people would like it and use it throughout the day. That's okay, but then usually it's meant for night. And there are some splints that have like the wrist cock-up. You actually don't want to have the cock-up braces, you want a neutral brace. Corticosteroid injections, do you guys, by raise of hands, do you guys inject the carpal tunnel? Okay, we'll discuss that in a second. If you haven't done a carpal tunnel injection, it could be a little bit scary in the beginning, especially if you hit the nerve. It's okay to poke it. It's not okay to poke it and continue to proceed with your procedure, okay? And so you have to change your needle. And it will scare the patient, and it may also scare you. So I usually tell the patients, when I put this needle in, if you feel an electrical signal, it's okay, just let me know and I'll change my needle, okay? Adjuvant therapies include NSAIDs, ergonomic modifications of work. So if you're typing and you're doing this the whole time, it may exacerbate your symptoms. You could send them to occupational therapy for nerve and tendon glides. There's also some other extra modalities, but the mainstay for non-operative treatment is night splints or corticosteroid injections. So indications for carpal tunnel injections, like I said, is mild to moderate disease. I usually don't inject for severe unless the patient cannot tolerate surgery, then I will inject it for severe. But then this is usually for mild and moderate. So if you look at the data out there, and our orthopedic data is not that great. It's not, we have a lot of level 4 studies and maybe level 10 studies. And so if you look at therapeutic, if you inject them at 6 weeks, 75% will improve, 75%, which is pretty good. But in 1 year, it's not that great. It's 20% symptom improvement in 1 year. I also like to use it diagnostically. So if I can't tell, if they say my entire hand is numb and just doesn't fit the distribution, and I sometimes give them an injection and I say, come back and tell me what got better. If everything gets better, then they will probably respond pretty well to surgery, because if they have a positive response, 87% have a surgical success. But if they don't really respond that well to the injection, it's a 50-50 shot, and you just let them know they may get better, they may not get better. It's a 50-50 shot. So the injection technique, the key is to know where is the median nerve. And the median nerve is usually ulnar to palmaris longus. The way you find palmaris longus is you take your thumb and your small finger, and then you flex it, and there's gonna be a tendon in the middle. The caveat is about 20% of people won't have a palmaris longus. And so that's probably not the right person to start a carpal tunnel injection. So find a patient who has palmaris longus and go ulnar to palmaris longus. But like I said, the median nerve does not read the anatomic textbook. So sometimes it will actually be ulnar to palmaris longus. So when you're putting in the needle ulnar to the palmaris longus and they feel an electrical ring, then you have to change the position of your needle. I've gone radial to palmaris in the past to inject the carpal tunnel, because once I introduced the needle, they had that zinging sensation. So be careful. When you're injecting, if they feel shooting pain in their fingers, you have to back off. You cannot inject into the median nerve. If you inject into the median nerve dies, okay? And then you start, I'm not trying to scare you. I think I did that. Ulnar to the, so you inject ulnar to palmaris. You start approximately at the proximal wrist crease, aiming approximately 30 to 45 degrees distally. And I usually go about half an inch with my needle. Go very slowly, I go in about half an inch. And when you inject, it should be smooth. I used to use 25 gauge needles. I've changed to 27 gauge needles, because even the 2 gauge, even this small difference actually makes a big difference in terms of pain. And you guys have also probably injected trigger fingers. There is a big difference in pain when you use a 27 for the trigger finger injections versus 25. And I use a steroid and lidocaine mix for that. So when to refer, I think when you try some non-operative treatment, you do night splints, they're not getting better. And I think that's a good indication to refer to a hand surgeon. or a general surgeon, general orthopedic or plastic or general surgeon that has carpal tunnel releases, moderate to severe carpal tunnel symptoms, or if you just can't quite tell exactly what's happening, it might be coming from the neck, then send it to us and we will figure it out. Surgery is we release the transverse carpal ligament, which can actually be up to 1 centimeter thick. It could be really, really thick. And you could do this under local or regional anesthesia. And so the surgery is basically in between the thenar compartment, the hypothenar compartment, somewhere in the middle there. And you could do open release, or you could also do endoscopic release, okay? I know there's some data out there that says you get to work a little bit faster, but then in reality, there's no big difference in terms of endoscopic or open carpal tunnel release. Now, the second thing you may see often is trigger finger. And the term for trigger finger is tenosynovitis, tendovaginitis, there's different terms. It's actually not inflammatory, but then that's the way I usually explain it to my patients, because it's a lot easier for them to, when I say you have inflammation because it hurts and then we inject steroids or give NSAIDs to get better, so we say it's inflammatory, but it's really not inflammatory. It's kind of like tennis elbow, there's like degenerative pathology. The way they will present to clinic, a lot of times they present with the pain at their PIP joint. And when I see a referral that says pain in the PIP joint, most likely, I would say 8 out of 10 times is probably trigger finger, okay? So I go and I press directly where the A1 pulley is, which I will show you where it is. There's 2 subtypes. There's a nodular type and a diffuse type. The nodular type is when you feel that little bump, and they actually do better with injections. They have a 93% success rate with that injection if it's acute, less than 6 months. So if you haven't injected trigger fingers, it's pretty easy to do and very high success rate, and I think it's something that you could probably easily take up in your practice. The diffuse type in diabetics, they actually don't respond that well to injections, 48% success rate with injections, okay? So like I said, it's variable presentation. If they have clicking or if they get stuck and they say I have to pull it open, then that's fantastic. It makes the diagnosis a lot easier. Sometimes they move their fingers and they don't click, they just have pain. So that may confound the picture, but usually the way I test that is pain at the level of the A1 pulley. So let me see if I have a picture there. So here. So if you see the distal palmar crease and then you have the finger crease here, the A1 pulley is right there, somewhere between those 2 lines, okay, the A1 pulley. Like I said, on the physical exam, you go and press here and they'll have pain. If they have pain there, that for me is trigger finger, okay? The thumb, the A1 pulley is at this level, at the crease, not down here, at the crease, and that's where you would push for the thumb. It's, like I said, most of trigger fingers are idiopathic, but there are also some secondary causes of trigger fingers, but most of them are idiopathic. In clinic, you may see, if you see pediatrics, they could have something called congenital triggered thumb. It's not congenital, it's actually acquired. And they will come with a flexed thumb, and what we usually recommend for that is, we give them the options. You could actually just watch it, and a lot of them will spontaneously resolve by about 4 years. But if they do want to have surgery for this, we wait until they're older because of anesthetic risks, okay? I think we usually wait until age 1, but then I think there's data showing that the longer you wait in terms of brain maturation for kids for general anesthetics, it may be worthwhile just to wait a little bit longer than that. But it has really good success rates. If you want to try to inject a triggered thumb in a kid, go ahead. I wouldn't do it. It's terrible. So it's up to you. Pediatric trigger finger. This is different. This is a different beast. So this should be referred to a hand surgeon because a lot of times they have anatomic anomaly, and those are surgical for us. So if you have a pediatric trigger finger, not a triggered thumb, a trigger finger, then you should refer to a hand surgeon. So non-operative options in adults. You could just watch it. Some people hate needles. They say, I just want to know what it is. And they try some NSAIDs. They may get better. There's this trigger finger ring or splint. Like I said, studies show steroid injection alone is more effective than the splints. But some people wear the splints. And what it does, it helps you not flex your MP joint. So you could use it if you want for your patients. I love corticosteroid injections for trigger fingers. I think they work immediately, and they have pretty good success rates. You also have operative releases. You could do it percutaneous and open, depending on your healthcare system. Some clinics are set up to do it in clinic. I think Kaiser does that often. And so you could do it in clinic, or you take it to surgery. Steroid injections, after a single injection, about 70% will resolve. And from our studies, if you start adding better studies, it drops to 57%. So I usually tell patients 50-50. The first injection, you have a 50-50 shot of getting a cure. And then if you come back and you get a second injection, I usually say that's also 50-50, you know? I usually don't do more than 2 injections for trigger fingers. If you fail 2 injections, then it becomes operative. In diabetics, I usually I do 1 injection, and then after 1 injection, if it fails, I usually recommend surgery unless they want a second, because diabetics don't respond as well to trigger finger injections, and the second usually is not curative for them. So so when I inject trigger fingers, you can inject anywhere. You can inject in the crease. What I like to do is just to go straight in the middle, and I think in the past, people thought that you have to go directly into the sheath, which may be sometimes hard. So people go down, hit bone, come back out, and try to inject into the sheath. And that's actually quite painful if you're jamming a needle into the bone. And so what I do is I just go subcutaneous, and there's studies showing that it's just as effective. So just poke through the skin, inject. And the key to doing it less painful is of course they'll feel the injection when you first go in. But then you have to use a smaller needle, 27 gauge needle, and just go really slow when you inject, okay? It'll help with the burning sensation. One thing, excuse me? No, because I have lidocaine in the mix. So I use lidocaine and steroid, I mix it. If you want to go overboard, which sometimes we do, is in my clinic, what I do, because we inject a lot, I take 8.4% sodium bicarb, and I make a mixture with my lidocaine. The pH of regular lidocaine is around 6.2, so if you take like half a cc of 8.4% sodium bicarb, which is like the 50 cc vial costs like $3, and you mix it into your 10 cc vial, then you bring the pH up to more physiologic, so it burns less. So the risk of injection, everything we do may have a consequence, so just let them know that they could get infections, fat atrophy, bleaching of the skin. If you inject directly into the tendon, you could get tendon ruptures. And then diabetics, you have to let them know about this, hyperglycemia in diabetics. So in diabetics, I counsel them, your sugar is going to be elevated for about 5 days, so don't freak out if it goes up, okay? And then by 5 days, it tends to go down. And the first 24 to 48 hours, you'll see a 150% spike over your baseline. So for surgery, we do surgery when they fail non-surgical treatment. So like I said, for non-diabetic trigger fingers, I do 2 injections. Diabetics, I tend to do just 1. If they fail, I offer them surgery. But then also if they come in and they can't strain their finger, they're locked, that becomes surgical. I don't inject those, I just take them to surgery. You have to fix this. So you could do percutaneous release. If they're clicking in clinic, you could actually put a needle and do it in clinic. You numb it up, put a needle, and you could saw the A1 pulley back and forth. Or you could do open release in surgery. So when to refer, failure of at least 1 injection, locked trigger finger, unclear diagnosis. Okay, this is going to go a little bit quicker. Basal joint arthritis. So what is the basal joint? When we talk about the basal joint, we mean the CMC joint of the thumb. So this is the IP joint, interphalangeal joint, MP joint, and then the CMC joint is down here. And so if you take your hand and you go down the dorsum of your finger, it'll be solid and it drops. That's where the CMC joint is. And this is pretty common. That's where the CMC joint is. And the CMC joint is a saddle joint, looks like a Pringle. And this is how they present. This is classical complaints. I have pain when I pinch or write. I can't open a jar. I can't turn the key. Shopping bags hurt. When I pinch and I try to use a knife, it hurts. Okay? So on clinical exam, some people, when they have severe CMC arthritis, the basal joint arthritis, they get dorsal radial subluxation. So what it looks like is a bump, a prominent bump here, okay? Because the joint is actually subluxing. And that's called a shoulder sign. It kind of looks like this. One thing to note that I wanted to just highlight here is that you could have CMC joint, and sometimes the MP joint is also affected. People will get compensatory hyperextension of the MP joint. Or some people have hyperextensible MP joints that leads to CMC arthritis. It's kind of like a chicken and egg theory, okay? So it could be either way, but then you have to, when you assess the CMC joint, you have to assess the MP joint, because sometimes you have to intervene here too. So what they do, there's a test called the grind test. So what I do is I stabilize the metacarpal, and I take the arthritic joint and I slam it together. That's called the grind test. So you grab it and slam it and you wiggle it. And if they have pain, there's a positive test, like that. Non-operative management, you could do OT referral for orthotic, but then you could also just send them to buy this Futuro splint. It's like a soft thumb wrap. They usually like that. Okay, let's see. CMC injections, these are kind of hard to inject because it's hard to get into CMC joint, especially if it's arthritic. If you have access to a fluoroscan, you could do it with a fluoroscan. But if not, these are kind of hard to inject, and they're actually quite painful. The patients will have a lot of pain when you inject it. And you know you're in the joint when they have pain, okay? So I do inject CMC joints. A lot of patients, if they can't do the rehab, because the rehab for surgery is, it'll put you back approximately 4 to 6 months. And so if you can't do it, I do injections. Later stages, sometimes we do CMC arthritis. This is for people who are manual laborers. They put a lot of force into their CMC joints. We will do arthrodesis. We fuse it. But the mainstay for us is something called resection arthroplasty. So basically, we have to take out the trapezium, one of the bones, and then we suspend it in some fashion or put something in there in the space. So if want to refer, failure of non-operative treatment or unclear diagnosis once again, okay? Quervain's tenosynovitis is, this is inflammation. It's not, okay, so Quervain's is also not inflammatory. It's kind of like trigger finger. We call it inflammatory, but it's not. It's like lateral epicondylitis. But then we also do inject steroids there too. So Quervain's is the sheath enclosing the APL, APB, so abductor pollicis longus, extensor pollicis brevis. So I call those the Applebee's, okay? The Applebee's becomes narrow, it causes pain. I put inflammation here, but it's not an inflammatory process. So this is where the location of, usually their pain will be, so this is the Applebee's over here, but then they extend here, and this is where usually the patients will have pain. And they may feel like they have a bone outgrowth because the sheath actually hypertrophies and gets really, really thick. And so they say, I have a bony growth here, but it hurts over here. And this is the extensor pollicis longus, but Quervain's is over here. So who gets the symptoms? Fortunately for me, women get it more often, but then new mothers, okay? New mothers get it a lot. I think it's the way you hold the babies, and babies double size every 48 hours, right? They get really big fast, and it might be some sort of ergonomic thing. But then they respond really, really well with injections. So on physical exam, the classic test is called the Finkelstein's test. So you put your thumb in your palm, and then you ulnarly deviate like this. So in medical school, they taught me to actually do that for the patient. I would not recommend that. It's really, really painful. Just have them put their thumb and then have them do it themselves. If they have pain, it's positive, okay? That's one of the tests. So let's talk about treatment. Quervain's tenosynovitis, you could do a thumb spica. If the thumb is involved, you do thumb spica, okay? That's usually the tenet of hand surgery. You could do activity modifications, eyes, NSAIDs. You could start with that. If they fail that, come back and get an injection. So how good are we at injecting? So NSAIDs, 0, okay? Doesn't really work from our literature. Maybe you have a different experience, but our literature says it doesn't really work. You could try it. Splinting, 14%, not that great. Injection plus splint, 61%. Injection alone, 83%. I'm not sure how this drops it. So, but people ask me, they're like, should I, you gave me an injection, should I splint this? And I say, well, our studies show that it's actually better not to, well, at least it's similar, you know? So if you want a splint, I can give you a splint, but then you don't need it. And then injection, 80%, 83% success rate, but may require often 2 injections. The reason we may not be as successful is poor technique. It's kind of hard, and they have pain when you inject, and you have to go through a really thick sheath to inject. And then there's something called an EPB subsheath. So the Applebee's are in one compartment, but sometimes it's subdivided, so you're not hitting all of the compartments. And so that's called the EPB subsheath. One thing you have to counsel the patients, if you look at the radial side of your wrist, it's very subcutaneous. If you inject steroid, not into the sheath, but by the skin, they'll get blanching of the skin, okay? What I like to use is water-soluble corticosteroids because it creates less local skin reactions. The Quervain's, tenosynovitis, the mixture is 1-to-1 lidocaine and a steroid, usually a water-soluble steroid, okay? And you would inject along the path of the sheath, and then sometimes you could, if you get it right, you could actually sometimes hear a pop. It's actually quite gratifying. So pregnancy, lactation, there's shifts in hormonal fluctuations and shifts in like third body spacing. And so, like I said, women who come with Quervains, I inject, and most of them do really well. Surgical treatment, so I usually do at the most 3 injections. If they don't react, they don't get better after 3 injections, then I open up the sheath. Surgery for me is last resort, okay? So these are some of the reasons to send them to a hand surgeon. You may see this in clinic, mallet finger, so someone might be playing basketball and they jam their finger, it's called a jam finger. And so they come with a droopy finger. So if you get an x-ray, you get a droopy finger because you had your terminal tendon that attaches at this portion is either ruptured or it has a fleck that comes off with it. So this is called a soft tissue mallet finger. So the bone is not broken. If you have a bony piece, then it's called a bony mallet. And the treatment is actually pretty simple. You have to keep them in extension 24/7 for 6 weeks, okay, 24/7. If at 5 weeks they take off their splint and they droop, then you start at 0 again, okay? And so it's 6 weeks, 24/7. And what I wanted to highlight here is when to actually refer to a hand surgeon, because you could treat this in your clinics, is when they have a big piece, and usually it says 1/3, but if you have a piece that looks like this, send it to the hand surgeon for possible surgical treatment. And then here, if you guys can see, this is volar subluxation of the distal phalanx. So basically, you lost joint congruity. That's when this is surgical for us, okay? Now, ganglion cysts, this is the Bible cysts, yes?
Patient presented 1 or 2 months later.
Yeah, so they present 1 and 2 months later, I still do the extension splinting. Yeah, so the thing is, if it's flexed inflection, we don't have really good solutions. And so if it's flexed inflection and it's painful, then usually it leads to a fusion. We fuse it, okay? And so if it's not fixed inflection, it's still like 3 months out, we try extension splinting because we don't really have good revision surgeries to give you normal motion. You usually fuse those. So now ganglion cysts, the Bible cysts, the bump on on your wrist, most of them are dorsal, some are volar. There's something called mucuses, which I'll define in a second. People have this cyst in their back of their hand, and a lot of times they come thinking it's a tumor. So for me, if I know it's the ganglion cyst, I tell them right off the bat, I say, it's not a tumor, you could live with it. If it doesn't bother you, I usually try to convince them not to do it for cosmetic reasons because then we're trading a bump for a scar. And every time we do a surgery, you could have a potential complication. And then also there's recurrence risks, right? So it could actually come back even with surgery. If it's painful, then yes, it is a surgical indication. And a lot of times these big cysts are not as painful as the occult ganglion cysts, the little bumps and the ones that you can't see, and you can only see with MRI. The ganglion cyst, the way you diagnose this, it's mobile or slightly mobile. You could take a pen light and illuminates. And usually if they say it goes up and down with size, sometimes it goes away, and then it's probably not a tumor, it's probably just a ganglion cyst, okay? And this is what an occult ganglion cyst is someone comes with persistent wrist pain, and then this is part of the differential diagnosis, occult ganglion cyst. So you get an MRI to check. The volar ganglion cyst is usually on the radial side. It's usually from the radiocarpal joint. And I'll tell you my bias as to aspirating or not aspirating in the next slide or so, but then some people try to aspirate the volar ganglion cyst, and you have to be really, really careful because a lot of times the radial artery is right there, okay? And you could, in the differential diagnosis is an aneurysm of the radial artery. During residency, one of my co-residents put a needle, and then he drew back in his blood, and they took it off and started squirting, and he hit an aneurysm. So be careful. If you have what's called, we call it like the ganglion cyst of the DIP joint right here, this is usually for us surgical because it's associated with an osteophyte, and they tend to recur unless you get rid of the osteophyte, okay? So if you see this, get an x-ray, you will probably have some sort of osteophyte, and that should be referred to a hand surgeon if they want to get it treated. So some people will aspirate. I don't like to aspirate myself in general, but then if you do aspirate, I think dorsal ganglions is reasonable. With a single aspiration on the literature, it says approximately 15% cure rate. If you do 3 or more, it goes up to 85%. To inject steroid or not, there's no conclusive evidence that it helps. So you can try it, but then just aspiration I think is good enough. Surgery is better in terms of recurrence rates. It's 4%. Like I said, the volar aspirations, you could still get some sort of decent response from aspirating the volar ganglion cyst, but like I said, be very, very careful. You could hit the radial artery, okay? Surgical recurrence rates in the volar ganglion cyst is somewhere between 7 to 33% recurrence rates. And it's been shown that patients who have, for some reason, if they have general anesthesia, they actually have lower recurrence rates, and I think it's because you're not rushing as much to do the surgery. And the volar ganglion cyst, it could actually, the stalk might actually go a little more distal to the CMC joint. And so I think that's why it's higher. Mucus cysts, I don't aspirate this in clinic because you actually put them at risk of infection for a low success aspiration. And like I said, they tend to come back unless you nibble off the osteophyte, okay? So that's my talk on common hand conditions. Thank you.